So in this video, we're going to discuss about mental status examination. It is a part of the clinical assessment. MSE occurs throughout the entire interview, during which you are constantly evaluating the patient. It includes your observations and impressions of the patient at the time of the interview. For example, you describe the patient's appearance, speech, actions, and thoughts during the interview, but it changes day to day or hour to hour. So it's the description and impression of the patient at the time of the interview. That is mental status examination. So there are a few elements of the mental status examination. So the basic outline of the mental status examination include appearance, behavior, attitude, speech, mood and affect, perception, thinking or thought, content and process, cognition, which includes alertness, orientation, concentration, memory, immediate, recent or remote memory, and some basic calculations, fund of knowledge, and abstract reasoning. The insight and judgment. These are the elements of the mental status examination that you do at every assessment of a patient. So in the initial part of the mental status examination, you look at the general description of the patient, their appearance, their attitude towards the examiner, their behavior, psychomotor activity, and speech. So when we look at the appearance, you look at the hair, facial hair, face, eyes, body, movements, or clothes. For example, in hair, you might mention it as curly hair if the patient had wavy hair, facial hair if the patient was shaven or unshaven, lately taken care of his facial hair, face if the patient has any red nose or flushed face or the face looks pale, eyes the patient made a good eye contact or patient had made an intermittent eye contact or the patient was downcast. Body, you look at if the patient is morbidly obese or patient is obese, patient is thin, or you can mention patient was muscular, and if patient had any tattooed arms or if they had any self-injurious behavior, like for example saw some cigarette burns or any cuts on her hands. Then for movements, you look at if the patient has any tremors, any tics, any abnormal movements, tremulous, looking rigid and motionless, or if the patient had a slumped posture. And also it looks if the clothes were appropriate to the weather, if they were casually dressed or neat, sexually provocative or flamboyant, if there are slogans on clothes. So that gives a general appearance. It doesn't have to be lengthy, but something that stands out to you or something that gives a good description of their behavior, appearance at that moment. So next is behavior and attitude. For example, how was the patient behaved at the interview? Was he friendly or cooperative? Was he indifferent or apathetic towards you? Was he agitated during the interview? Was he pacing around the room and talking rapidly without really attending to your questions? The patient can be friendly, cooperative, kind of seductive, defensive, guarded. So these are some attitude towards the examiner that you can mention. Next is, so in the speech, you mention the rate, volume, latency of response, and general quality of speech. For example, rate, if the patient spoke rapidly or very slowly. Sometimes when the patients are manic, their speech can be rapid or pressured, or maybe kind of the patient is depressed, the speech can be slow. Sometimes during anxiety too, the rate of speech can be faster. Next is volume. If it was loud or soft-spoken or quiet, so that signifies something again. So loud, maybe a patient may be manic, or may be irritable, or maybe anxious, and a very low volume may signal depression or maybe shy. Maybe that's the normal way they'd speak. Next is latency of response. Latency is when you ask a question to a patient, they think for a fraction of a second, right? That is called latency of response. If it is increased latency of speech or decreased latency of speech. So for example, a depressed or a psychotic patient may have an increased latency of response. Increased means there is a long pause before answering the questions. That is called increased latency of response. Or maybe in case of patients with mania, they will jump to the answer immediately, even before you finish the last few words of your question. So that is decreased latency of response. Then the general quality of speech. For example, was it articulate? Was she just rambling, or was she hard to follow? So did the patient speak thoughtfully in an articulate manner is what you're looking in the general quality of speech. Another aspect of mental status examination you describe is their affect and the mood. So mood is pervasive or the sustained emotion of the patient. Carlett defined it as a subjective report of how a patient feels. For example, mood can be described as anxious, depressed, euphemic, or maybe you can even write as euphoric. Patient feels hopeless, or mood is labile, which means alternating. For example, in one moment the patient is laughing loudly and expansive, and another moment the patient is tearful and despairing. So the mood is labile. So you can mention it that way. Next is affect. Affect is your own impression of what's the patient's emotional state. If the affect is appropriate to the mood, the affect may be anxious, like the mood was anxious, so you might write, okay, affect is appropriate. Or you may write, the patient did not have any emotions at all. So that kind of puts it into as if the patient had a constricted affect, or if the patient had a blunted affect, or if it was flat affect. For example, when you write a constricted affect, that is when the range and intensity of expression are reduced. In blunted affect, the emotional expression is further reduced. And to diagnose a flat affect, there is no signs of affective expression should be present. The patient's voice is monotonous and the face should be immobile. So in those scenarios, those cases of affect can be seen in patients with extreme depression or patients with schizophrenia. Next is perception, that includes how a person perceives the world. For example, hallucinations and illusions. Hallucinations is when the person can feel that there's something talking to themselves, or feel that there's something they can see but others cannot, or they feel something, they feel a different taste. So that is hallucination. Then it's not real to another person, but it's real. It may seem real to them. So it includes auditory hallucinations, hearing voices, visual hallucinations, seeing something which is not there, and tasting, kind of taste on their tongue, olfactory hallucination, some kind of smell, or tactile hallucination, something's touching, or feel the worms crawling on the hands. Another type of perception is called formication. Formication is also kind of feeling that the bugs are crawling on or under the skin. That's called formication. That is usually, it's a kind of perception in case of alcohol use disorder, or in case of cocaine use disorder. Next is illusion. Illusion is when you see there is actually something there, but you perceive it as something else. For example, when you see a curtain, you feel that there's somebody there. Or at night, when you see the curtain, you feel that there's something, or you perceive that curtain to be someone else there. That's called illusion. So coming to thought process. The process or form of thought refers to the way in which a person put together ideas and associations, the form in which a person thinks. So it can be described as linear and logical. And other formal thought disorders include circumstantiality, tangentiality, looseness of association, flight of ideas, word salad, poverty of thought, racing thoughts, thought blocking, neologism, or perseveration. These are the different formal thought disorders. So let's look at circumstantiality. So that is beating around the bush but coming back to the point. So over inclusion of trivial and irrelevant details when you ask a question, that is circumstantiality, but eventually the person comes back to a question, answers your question. Second is tangentiality, that is just beating around the bush but never comes back to the point. For example, when you ask, have you had any trouble sleeping lately? The patient might say, I usually sleep in my bed, but now I'm sleeping on the sofa. That is tangentiality. Next is looseness of association. That means here the patient brings about ideas which is unrelated and idiosyncratic. That is looseness of association. Whenever we ask a question, but each point is different, but you completely lost what the patient was saying. That is looseness of association. Then the flight of ideas. Flight of ideas is similar to that. It's kind of patient has a lot of thoughts coming into the mind and it completely derails your conversation. Next is word salad. That means the speech has become so loose that it has become incoherent and incomprehensible. There's no connection of thought. That is called word salad. I don't know how do you pronounce it, word salad or word salad. Okay, how that is, word salad. Next is clang association. That is association by means of rhyming, and that's called clang association. Then there's poverty of thought, where the patient is not able to, they have interruption of thought. They are not able to think through that. Or maybe thought blocking, a sudden interruption of thought, or break in the flow of ideas, that is thought blocking. Or racing thoughts, that is kind of like in a patient with mania. A patient has lots of thoughts coming into the mind, pressured speech. That's called racing thoughts. Next, moving on to the content of the thought. It refers to what a person is actually thinking about, ideas, beliefs, preoccupations, or obsessions, which include delusions, ideas of suicidal ideation or homicidal ideations, or like obsessions, which are thoughts which are intrusive and repetitive. So, for example, a person might think, my hands are dirty, so washes and washes and washes again. After a few minutes again he feel like, no, it's dirty, so he goes wash again and again. How it causes a repetitive. He knows that it is intrusive and he knows that it is repetitive. That is obsessions. Or preoccupation, for example, preoccupation about an illness, that maybe I may have an cancer, or because of this COVID, I'm preoccupied with corona. What if I contract this disease? I should not go out. Let me stay home. People are trying to harm me. That is another thought of belief. A patient is there trying to harm me, or somebody is talking about me. Ideas like ideas of reference, of delusions. That I'm God and I have superpowers. That is kind of grandiose delusions. Delusions are part of that too. Or any kind of ideas like suicidal ideations or homicidal ideations. So that is the content of thought. So cognitive examination, you assess for the level of awareness. You assess for their sense of alertness, their attention, concentration, memory, fund of knowledge, abstract reasoning, certain calculations. So level of awareness is mainly by observation. you're writing if the patient is alert, patient is drowsy, or patient is stuporous. Next is orientation. Orientation. Here you're assessing if the patient is oriented to time, place, person, situation. So what's the time, what city are we in, where is it located, what do you think we are, and then concentration. You can arouse concentration by attention. You can arouse attention by asking serial subtractions of 100 to 7. So 100 minus 7, you ask the patient to count down to single digits from 100 minus 7, and there, or 100 minus 3, or if that's too difficult, 20 minus 3. Another way is to say the letters of the alphabet backward, starting with the Z, or name the months of the year backward, starting with December. So you're arousing their attention, and if the patient was able to sustain the concentration during that time. Then the memory, you assess the immediate memory, recent memory, and the remote memory. For assessing the immediate memory, you send us some numbers and ask the patient to repeat those numbers. For example, 14925. So the patient says, okay, 14925. Recent memory, for example, what did you have for breakfast? You should know what did they have. If the patient was an inpatient, you could ask, clarify that from others, and then you ask that question. Okay, so what did you have for breakfast? And or you may be asking the patient to remember 3 things and ask them after 5 minutes. So you tell them, okay, you remember 3 things, and I'll ask you after 5 minutes. For example, yellow pencil, a Cocker Spaniel, and Cincinnati. Then you ask about, after 5 minutes, you ask them, oh, I asked you to repeat, memorize something. Do you know what that is? So that is to assess the recent memory. And the remote memory is from the past. So what was the name of your first teacher, or what was your address when you were in 3rd grade, something in the remote. Then calculations, some simple calculations. Maybe if you buy something that cost $3.75 and you have a bill of $5, how much change should you get back? Or similar calculations. Then to assess the fund of knowledge, you can ask, can you name the 5 presidents in the United States? Last 5 past presidents of the United States. You should know it first, okay? And then the abstract reasoning. So in that case, you can ask a proverb, and what do you mean by that proverb? For example, a stitch in time saves 9. So what's the meaning of that? You should know the meaning first before you ask the patient. Or for example, another one is similarities or differences. For example, how are an apple and an orange alike? Or assessing which one does not belong in the group: a pair of scissors, a canary, and a spider, and why? Next, you are assessing judgment and insight. Judgment, you're assessing the personal judgment, test judgment, and social judgment. So the personal judgment is basically, are they aware of their illnesses and what are they gonna do about it? So that's personal judgment. Or social judgment, how do they feel about the society, or how is their intimate relationship? So these things you are assessing throughout the history taking. You are assessing this personal and the social judgment, right? The next one is test judgment. Test judgment, you are giving a test and asking them what do they do during that in that situation. For example, if you smell smoke in a new movie theater, what would you do? Or if you find a stamped envelope on a street, what would you do? So that is assessing the test judgment. Then comes the insight. Insight is emotional degree of awareness and understanding about being ill. There are various levels of insight, maybe ranging from complete denial of illness to true emotional insight, where the patient is aware about their motives and feelings within the patient, and they identify important persons in his or her life and identify ways to change behavior. That is true emotional insight. So the insight itself can be divided like complete denial of illness, slight awareness of being sick is the second one, and needing help, but denying it at the same time. Third one is awareness of being sick, but blaming it on others, on external factors or on organic factors, or awareness that illness is caused by something unknown in the patient, or intellectual insight, where admission that the patient is ill and symptoms of failures in social adjustment are caused by patient's own particular irrational feelings or disturbances, but he does not apply to future experiences. And the final one is true emotional insight. So ranging from complete denial of illness to true emotional insight. So to conclude mental status examination, so we saw that it is an important part of the clinical assessment, and it is your observation and impression of the patient at the time of the interview. And we saw that it includes appearance, the speech, actions, thoughts, their attention, concentration, memory, judgment, and insight. These are some essential aspects. It changes day to day or hour to hour. So that is mental status examination. You, as a mental health nurse, you would do a mental status examination at every visit with the patient. Thank you.